versus 56 in the control group. Overall 3 years overall survival were 80% in the study group as compared to the 70% in the control group. And PS is also favoring the surgery arm or local therapy arm as compared to the only ADT. So there are certain limitations to this study that certain patients have not strictly followed up the protocol. Conventional imaging were used which has low sensitivity. Treatment group were heterogeneous, and median radiographic progression free as well as overall survival was not reached as the short follow-up of this study and relatively small sample sized. So they concluded that newly diagnosed oligometastatic prostate cancer ADT with local radiation therapy have better radiographic progression free as well as overall survival. So RP should be considered in such scenario. Thank you.
Thank you, Rupesh. Again, we had a very interesting panel discussion, and it actually addresses the same question we were discussing, that whether local therapy in an oligometastatic setup would be beneficial or not. At least in a phase 2 setup, they have showed that it does work for 3 years for a short follow-up. So we need to wait for a longer follow-up, and the data needs to be more mature before we are there. But that's an interesting thing which has already begun. So that's why we thought it would be one of the practice-changing sessions. Anyone has any comments or opinions to share?
Okay, thank you.
Yeah, thank you, Rupesh. So we move on to the next paper.
Dr. Manoj Tumala, who is a consultant urologist and uro-oncologist from Chennai Urology and Robotics Institute, Chennai.
Yeah. Good afternoon, everyone. The paper given to me is on Keynote trial 564. So it was a pembrolizumab versus placebo. It was a randomized controlled trial, which is the multicentric. So we all know that people with post-nephrectomy, there is no good adjuvant therapy from past 3 decades. And even the VEGF tyrosine kinase inhibitors, they don't show good results when they are used in the adjuvant setting. Even though the sunitinib showed some results, but there is no strong evidence to suggest as a therapy for patients. And in patients who are having high risk, particularly with a T stage and high nuclear grade and having a sarcomatoid futures, so those patients who require adjuvant therapy, those patients can be benefited. And patients who are having a oligometastatic RCC, which can be resectable and who are disease-free, are those patients which can be put for these adjuvant settings. So it's a multicentric randomized double-blind placebo-controlled trial done from 2017 to 2019. And all the histological confirmed clear cell RCC patients with or without sarcomatoid futures are included in the study. And apart from that, the patients who are are classified into intermediate and high risk based on the pathologically T2 staging with sarcomatoid futures or T3 with any grade. And high risk patients including pathologically T4 and N plus disease. And M1 patients who had a oligometastatic disease which is resected completely, and there are no evidence of disease when undergoing treatment. So the inclusion criteria include good ECOG, undergone surgery within the 12 weeks before randomization, and they are disease-free when they are included into the study, and there is no history of any PD-L1 usage before. And any major surgeries which are done recently, they are not excluded. And any previous history of radiotherapy and previous use of any anti-PD-1 or PD-L1 usage and pre-existing brain and bone metastasis were excluded. So pembro and placebo both were given this is every 3 weeks up to a maximum of 17 cycles. And dose interruption and dose continuation with grade 2, the dose interruption is allowed, and we can start the patient again on pembro. But once it is discontinued, they are not kept on pembro again. So total 1,406 patients were included in the study, and they are equally randomized on 1:1 ratio. And finally, 496 patients are assigned to pembro and 498 in placebo. So the outcomes were, the primary endpoint was whether they're disease-free, and secondary endpoint was there is an improvement in overall survival. And additional secondary endpoints include tolerability and disease-free survival based on PD-L1 status. So these are the characteristics, and both the pembro and placebo patients are equally placed when you see the disease risk category in M0 and M1 NED, and even in the sarcomatoid futures also they're equally distributed, and PD-L1 also they're equally distributed. So coming to the disease-free survival, this is a follow-up study that is in 30 months follow-up. The earlier paper which showed 12 month and 24 month, they continue to show advantage of using pembrolizumab when compared to the placebo. Even the 30-month follow-up study also shows there is a 10% difference by using pembrolizumab in these patients. So coming to the subgroup analysis of the DFS, patients who are in metastatic disease, that is M0 intermediate and M0 high risk, and particularly patients with M1 with no evidence of disease had a good response with using pembrolizumab. So you can see that there is a 40% benefit of your patients, particularly patients with M1 and NED. And sarcomatoid features, there's a 20% difference when they use a pembrolizumab in the adjuvant setting compared to placebo. But the overall survival, there is no statistically significant data which is available right now. With the coming, the data will be more matured when the study comes to Coming to the recurrence pattern, 108 patients in Pembro had a recurrence, in which 13 had local recurrence, and 90 patients were having a distant metastasis, and 5 patients had both a local and distant metastasis. In 166 patients in placebo group has a recurrence, and 26 patients are having local recurrence, and 131 patients were having distant metastasis. At 30 months, the participants who were alive and had not had any event was 70.6% in the pembrolizumab group and 64.8% in the placebo group. Coming to the safety, patients who are having a pembro having a high adverse events when compared to the placebo group, and particularly patients who are having grade 3 and grade 4 adverse events are more in pembro when compared to the placebo, but none of the patient had any treatment related death or any treatment related adverse event. So most of the patients who had a thing is either they'll have some sort of hypertension and increased adrenal insufficiency and hypothyroid and hyperthyroid issues, and which require some sort of corticosteroid usage. Otherwise, no deaths are seen in. So to conclude my paper, this adjuvant pembrolizumab continued to show a benefit in disease-free survival, and recurrence-free was approximately 10% higher, and it has a statistically significant and meaningful improvement in patients with sarcomatoid and nuclear grade 4 and M1 and no evidence of RCC. And safety results were in line with the expectations, and no new safety signals were observed. And it is the only randomized control trial which supports the use of adjuvant therapy, and it has a potential to be a new standard of care in adjuvant setting. So the limitations are they used only the clear cell RCC in the study. There are no other subtypes are included. And the overall survival data was immature, and additional follow-up is needed to address this key secondary endpoint. Thank you.
Yeah, thank you, Dr. Tumula. Again, an interesting paper. Although it has definitely shown it got an FDA approval because of this paper that Pembro can be or should be used in the adjuvant setting. So that's interesting, and in fact, if you go into the literature, there are multiple studies going on. Eventually, we would have a better answers to them where they are evaluating all the entire immuno-oncology basket is being evaluated. Maybe it's Exitin, maybe it is avelumab or pembrolizumab or the other molecules. So it's an interesting landscape. Eventually, we would have better answers to that.
Yes.
Any comments from the audience? Sir.
I have one comment. This is actually grouping both sarcomatoid component present and absent. Most of the studies now which have dealt with sarcomatoid have mentioned, in fact, doublet, IO combinations to be required to achieve good adjuvant effects. Here we have used single agent. So I think we need to probably intensify therapy if you have sarcomatoid component in RCC.
Okay.
So to answer to that comment, this is a subset where it is M0 disease. So they have done radical nephrectomy, even if there is a single met, they have done metastatectomy, and then they have given adjuvant Pembro for 1 year. So in that they are showing. But this data is not, the samples of those never calculated for sarcomatoid per se. So that part has to evolve eventually.
In this trial, did they included patients who had clear cell carcinoma, RCC with T3A only disease?
No, so they included T2 with the sarcomatoid features, T3 with any grade.
No.
They included, sir.
If T3A.
Yes, sir, they were
T3
included.
included.
They included,
PT3 with any grade.
T3 with any grade.
In real world setting, in our practice, how long you will like to continue pembrolizumab? Basically, they have used for 1 year,
Yes.
but whether 1 year is optimum, 6 months is optimum, how long? Because this is a very difficult question to answer, even patient has sometime. So,
So,
I think that would be better answered by medical oncologist if anyone is here in the audience. Here in the paper, they have used for 17 cycles,
1 year.
3 weekly, that about 1 year, yes.
Adjuvant is 1 year, and metastasis they say 2 years.
Yes.
so whether after this paper, if you patient is not affordable for pembro, then whether you will give anything else, any TKI?
No, we have sunitinib, some evidence which is debatable whether it will really work or not. So that's the only thing we have at this point of time.
Right.
Thank you,
Thank
sir.
you.
Yeah, thank you
for
very
the
much.
opportunity.
Thank you, Dr. Ravi Mohan Mavuduru, for moderating this session. Next, we have a keynote lecture from our esteemed international faculty. And to chair this session, I would like to invite two more expert chairpersons, Dr. Sudhir Rawal, who's a medical director and chief of uro-oncology from Rajiv Gandhi Cancer Institute and Research Center, Delhi, and Dr. Vineet Talwar, who's a director medical oncology at RGCI, Delhi. I hand over the session to the chairpersons and invite our speaker, Dr. Shilpa Gupta, to talk on immunotherapy in bladder cancer. Is this the new SOC irrespective of the stage? Dr. Shilpa Gupta is a director, genitourinary oncology, clinical professor of medicine at Cleveland Clinic, Taussig Cancer Institute, Cleveland, USA. Ma'am, you have 15 minutes for your time and 5 minutes we have for discussion. Thank you.
I would like to thank the organizers for this opportunity. I'm really honored to be here and visit Tata Memorial Center for the first time. Thank you, Dr. Rawal, for the invitation. So we'll first discuss the role of immunotherapy in non-muscle invasive bladder cancer. This is the disease spectrum all of you are aware of. There's non-muscle invasive bladder cancer, muscle invasive bladder cancer, and then advanced bladder cancer. We know that alternatives to cystectomy when BCG fails the patient can be BCG interferon and a variety of other intravesical agents. But the focus of this talk is on systemic immunotherapy. Pembrolizumab is FDA approved in the US for BCG unresponsive NMIBC with carcinoma in situ at this point. And this was the study that got the approval of pembrolizumab. Initially, there was 41% complete response rates at 3 months. However, over time, only 19% of patients maintained that response. So it was not felt to be a durable response, and the activity is only modest. However, it is the only drug approved right now. And there was another study, SWOG 1605, which used a similar patient population as in the Keynote 057 for pembrolizumab. And in this, the complete response at 6 months was 27%. And they also had a mandatory biopsy at 6 months, which was not seen in the pembrolizumab study. And even though the updated results are quite comparable, this is not FDA approved in the US. There are a variety of ongoing phase 3 trials in the BCG unresponsive as well as BCG naive setting, in the phase 3 setting in the US and around the world. And we will see what the activity of pembrolizumab or other immunotherapies with BCG is. Nadofaragine Ferradinovec is a viral-based vector which has also shown a lot of efficacy in the high-grade BCG unresponsive NMIBC. These results were presented last year, and this drug is also FDA approved. However, it's not currently available in the US, and hopefully later this year it will become available. In this, as you can see, the responses were much better than what we saw with pembrolizumab, and everybody in the first 3 months had a complete response. The long-term durability we have not seen yet. TAR-200 is another novel drug delivery system for sustained local release of gemcitabine in the bladder, and it relies on an osmotic system for sustained release. And this study, the Sunrise series of studies, looks at low-dose gemcitabine, which is put in this pretzel, and it has shown very good activity in the Sunrise 1 study, where they combine it with a checkpoint inhibitor, sertralimab, which was given systemically. And as you can see, 73% of patients achieved complete response with this combination. And this shows a lot of promise. However, it is not currently approved. In conclusion, there are multiple options that exist for BCG unresponsive disease. Systemic immunotherapy is the only drug approved in the US. However, in the context for places like India, we need to really weigh the modest activity with the costs and toxicities. And TAR-200 and immunotherapy does appear promising, however, not yet approved. Moving on to muscle-invasive bladder cancer, we know that we just saw the journal club here that neoadjuvant cisplatin-based chemotherapy improves survival. However, there's still a high risk of recurrence after surgery. There's a lot of patients who are not cisplatin eligible, and there's a lack of neoadjuvant options for these patients. For adjuvant therapy, the ultimate goal should be to improve disease-free survival and overall survival. And in the earlier studies done with chemotherapy, we have seen improvement. However, there's not any randomized trial to show the adjuvant chemotherapy's improvement. The meta-analysis have shown overall survival improvement. There are several adjuvant immunotherapy trials that have been completed. The phase 3 IMvigor study looked at atezolizumab versus observation. However, this was a negative study for high-risk patients, no disease-free survival or overall survival improvement. The CheckMate 274 in an identical patient population compared nivolumab and placebo. This showed disease-free survival improvement, but we have not seen any overall survival data. Adjuvant pembrolizumab study, Ambassador has completed accrual. As we can see here, atezolizumab was a negative study, and this was the CheckMate 274 study, where 1 year of nivolumab was given and the median overall survival was improved by about a year. And patients who received neoadjuvant cisplatin-based chemotherapy were the most to benefit from adjuvant nivolumab. However, we have not seen any overall survival benefit. And we also saw from the IMvigor study that patients who had ctDNA positive disease had improved DFS and OS with atezolizumab. However, this was the post-hoc analysis, and there's a prospective study now going on to look at the value of ctDNA. But this data looks pretty convincing